Hey guys, I'm Mike. I'm a general practitioner working in Greater Manchester, UK. And in this short video, I want to share with you my afterthoughts on topic 6, back pain and sciatica, and elaborate a bit more on ankylosing spondylitis. We'll do this by going through the key elements from the history that might suggest the diagnosis, talk about investigations, and how and when to refer. Finally, if you stick around to the end, I'm going to share with you the most important way to prevent back pain and neck pain on Zoom and Microsoft Teams. So let's get started. Some lectures just stay with you, like the lecture about STIs being like wolves, or the lecture about underestimating your income and then paying the extra outstanding pension contributions, rather than overestimating, overpaying, and hoping that PCSE will one day pay you back. And one lecture that really stuck with me was from a young physiotherapist who was talking about ankylosing spondylitis, and she said that AS is a trap. It's a diagnostic momentum cognitive bias trap. It's a not another back pain patient trap. She subsequently set up an ankylosing spondylitis support group that helped patients who were being misdiagnosed for 20 and 30 years and now had long-term complications such as spinal deformities. Part of the great work that she was doing was raising awareness amongst young clinicians. So let's try to continue that and dive straight in. Your 4 key elements from the history are: number 1, less than 45 years of age; number 2, back pain for more than 3 months; number 3, back pain that is worse in the morning or wakes patients up in the second half of the night and generally improves with exercise or movement; and the 4th feature is morning stiffness that lasts for more than 30 minutes. Now, the way to catch AS is getting back to basics, using your Socrates acronym. I mentioned diagnostic momentum, which basically means if patients have been labeled as having mechanical back pain, there is that risk that we're just going to run with the diagnosis rather than retaking the history. We'll just end up giving them some naproxen. Remember, it's twice as likely in men. It can run in families, and there can be extra articular features such as uveitis. Untreated, patients suffer with long-term complications such as spinal fractures, spinal deformities, and osteoporosis. In terms of investigations and tests, well, I would pretty much liaise with your rheumatology department, but you can help speed up the diagnostic process by offering a pelvic x-ray. And what we're looking at are the SI joints, because inflammation in these joints is one of the diagnostic criteria. Regarding referrals, if someone is under the age of 45 and has 4 or more of these symptoms, you can refer. And this list is from CKS. But personally, I wouldn't worry too much about the list. You will get an idea of what you're dealing with just from that initial history and focusing on the key elements that we talked about before. You can provide your patients with non-steroidal anti-inflammatories plus minus gastroprotection if appropriate, whilst they're waiting for their specialist appointment. And when they finally see their specialist, they might be offered DMARDs, physio, OT, some kind of follow-up. Now, if you want to look smart, you should always mention HLA-B27. Chances are most people will stare at you in awe, won't really follow up with questions because we've all heard of it, but not many of us have actually done any extra reading on it. It's basically a gene, the human leukocyte antigen B27 gene, and 9 out of 10 patients with AS have this gene. Interestingly enough, 8% of the general population have this gene, but that doesn't correlate to the prevalence of AS at all. Other diseases thought to be related to this gene are psoriasis, IBD, and reactive arthritis. Finally, I promised you a bonus at the end, the most important tip on how to prevent back pain and neck pain whilst on Zoom and Microsoft Teams. Here it is in 3 words. Lift your screen. Now, I do a lot of Zoom meetings, and too often do I see people hunched over like this, or even worse, like this. And that's especially if they're on their iPads or other small devices. This is a switch, obviously. So do yourself a massive favor, buy a separate keyboard, prop your laptop on a box or a riser, try to get the camera more or less at the same level as your eyes, and your back will thank you. Right, that's it guys. I hope that was informative. If you need any suggestions like the riser that I use, just ask for it in the comments below. If you'd like to see more videos like these, please subscribe. You can also email me directly. Otherwise, good luck.